My name is Steven Horowitz from Memorial Sloan Kettering Cancer Center, and I'm going to talk about our study combining romidepsin to duvelisib and seeing how we think romidepsin may add. Um, so, of course, romidepsin is approved in the US for relapsed or refractory peripheral T-cell lymphomas and cutaneous T-cell lymphomas. And in the peripheral T-cell lymphoma group, the overall response rate was between 25 and 30%. In subsequent data, likely higher among those with angioimmunoblastic or follicular helper T-cell lymphoma subtypes. So we initially undertook a phase 1 study combining romidepsin with duvelisib based on some preclinical synergy. Duvelisib, of course, is FDA approved at a dose of 25 milligrams twice daily for low-grade B-cell lymphomas, though we had some experience in the phase 1 study of a 50% response rate in about 16 patients with T-cell lymphoma, although at much higher doses, a maximum tolerated dose of 75 milligrams twice daily. So with that background, we undertook a phase 1 study, and we saw that we could safely combine romidepsin with duvelisib at a full dose of duvelisib, 75 milligrams twice daily, and a dose of romidepsin of 10 milligrams per square meter. We didn't go higher than that in romidepsin, even though the FDA-approved dose is 14, but that was the highest dose we looked at. And based on what looked like particularly good activity in the combination in peripheral T-cell lymphoma, we then expanded and have now treated over 50 patients with that. And that was the data I presented at Lugano. And it looks quite good. The overall response rate was high. The complete response rate was high. A significant number of patients were bridged to allotransplant with curative intent. And we saw responses that we think were quite a bit higher, certainly than we see with romidepsin alone. And we powered the cohort statistically to exclude that response rate of romidepsin. So with that combination, we think the combination is better compared to single agent romidepsin in terms of efficacy. As the duvelisib data is emerging from the registrational study, the preliminary data is showing a response rate of duvelisib as a single agent at around 50%. And we did not have power to say that this was definitely higher than 50% given with the combination. So I'm confident the combination has higher response rate than romidepsin as a single agent. We're not yet confident or statistically confident the combination has a higher response rate than duvelisib alone, but it might have a higher CR rate. I think the other interesting thing we saw is when we gave duvelisib at 75 milligrams twice daily in the phase 1 study, we had about a 40% rate of a grade 3 or higher transaminase elevation. And when we combine duvelisib with romidepsin, that rate drops to about 10% or so. So we think in addition to the romidepsin perhaps improving efficacy, it may also provide a safety in perhaps blunting some of the inflammatory side effects one could get with PI3 kinase inhibitor or duvelisib. And therefore, it may also play a role in terms of additional safety or allowing longer full dose or high dose duvelisib, and there may be an efficacy benefit there too. Interestingly, we get into small numbers here, but most of the patients on the study started with a combination of duvelisib and romidepsin. But we did a small lead-in cohort of duvelisib single agent for one cycle just to get some biopsies on single agent duvelisib to try to sort of look for biomarkers of response or resistance. And in the patients who start with a single cycle of duvelisib and then go to romidepsin, they look like they had a higher rate of transaminase elevation. So there may really be something about adding romidepsin in combination that blunts some of that inflammatory side effect. So I think in answer to the question, does romidepsin add to the efficacy or tumor response in peripheral T-cell lymphoma? I think the combination showed a high response rate in a small study that we did, though it is over 50 patients and it was multi-center, so that's not a trivial data set in T-cell lymphoma. And then in addition to possibly higher efficacy, we think there may be a improved safety signal there and probably worthy of looking at this further.